Sometimes we take out the sand and we find a new way. And this way, which is now the presbyopia, we are not sure where we can arrive to. This is the same problem as in life. In life, there's an indefinition. Even when we born, we have a lot of questions, to be or not to be. We think about this a lot of time, and finally we find that the best solution is perhaps the indefinition. The indefinition when we are a child, the indefinition when we are bigger. And so we can find that with a reversible brand, we change every day and we feel better and quite different. Why? This is the same problem with multifocal or monofocal. When we have a patient with a cataract in our clinical, patients and surgeons are nowadays doubting. We spend a lot of time explaining, and why not to change this doubt about multifocal or monofocal approach by indefinition. That's why we make a rethink about this, and we saw that there were some multifocal piggyback implantation using the multifocal intraocular lens in 5 hypermetropic patients. There were also one patient with a bilateral ciliary sulcus implantation of a secondary piggyback multifocal intraocular lens. Some patients we had with a special refraction, we used a piggyback because we didn't have the multifocal lens to use to treat them. And using a IOL for emmetropy with a multifocal IOL of null diopters for the multifocality. So why not to do this in a small study? We treat bilateral cataract with no risk factors and good endothelial count cells. The patient didn't want the multifocal lens, so we explained to the patient the indefinition, the potential reversibility of the surgery. If we use a phaco plus an intraocular lens for the refractive problem, and then an multifocal intraocular lens with null diopters. Then they accepted. We explained them that if they had a problem, if they were not good with their multifocal solution, we can explant very quickly and easy the second lens, which is in the sulcus. So we do a phaco plus normal IOL with intracapsular ring always, and a standard Stabi-Back lens, and acrylisa null diopters in sulcus. Those are the results. Those are the table of our patients, of our results. And in fact, the results are that 70 patients with bilateral cataract surgery, so 34 eyes, 9 myopic patients, 8 hypermetropic patients, -10 to +5 diopters, finish with a far visual, uncorrected visual acuity, postoperatively or of 100% more than 20/30 and 59% more than 20/20. Lecture and computer have similar results because, as you can see here, we measure the visual acuity at 30 centimeters, 50 centimeters, and 6 meters. There were no complications intra or postoperatively. There were a good acceptation. I remind you that the patients didn't want the multifocality at the beginning. There were no multifocal lens extraction, and 100% of those patients were happy. We need long-term results, of course, but what we are doing now is making reversible the monofocality. Patients with a previous cataract surgery, pseudophakic patients, this morning we have problems to treat them with those solutions that we have for phakic patients. So why not to use a monofocal with the monofocal IOL, a new multifocal IOL with null diopters, an acrylisa IOL sulcus implantation as a new perspective for the monofocality. Thank you very much.